Good afternoon, and maraming salamat sa taking ko lang. Kasi may kailan yung sasabihin ko, natatakot ko mas mahaba pa yung lang. Alright, so as mentioned, what is ERAS? ERAS is enhanced recovery after surgery. I think it is timely because our theme for this CME 2 days are paradigm shifts, future perspectives. And ERAS is really a paradigm shift in how we manage patients who undergo surgery. I'll try to make this simple and short, knowing that majority of you are not surgeons. However, many of you may undergo surgery at some point in your life, or may have relatives who will undergo surgery at one point or another in their lives. So, these may be important things you may want to take into consideration as you go to the pathway of being a future potential surgical patient. So, what is ERAS? ERAS is a multimodal perioperative care pathway that has been designed to achieve early recovery or earlier recovery of patients who are undergoing major operations. It's called a paradigm shift because, one, it examines traditional practices and has in fact replaced some of them with evidence-based practice. And this is an important pillar in the paradigm shifts that we're seeing today. We're seeing more patient-centered care and more evidence-based and outcome-based. It is comprehensive in scope and covers all areas of the patient's journey through the whole surgical process. I think I have to speak louder because I'm So look at this. The whole process of ERAS is, as mentioned, comprehensive. It starts all the way from pre-admission counseling, all the way even to perioperative oral nutrition, part of which will be discussed by Dion, Sakdala, and subsequently. So it involves issues like no longer giving bowel prep to patients who will undergo colon resection, fluid loading, no administration of pre-meds. So this is an anesthetic concern. No need for nasogastric tubes. You'll be happy with that, of course. The use of mid-thoracic epidural anesthesia, short-acting anesthetic agents, avoiding sodium or fluid overload, trying to make your surgeries with small incisions, not using any drains, keeping your patient warm in the theater, routine mobilization, meaning ambulating your patient as soon as possible, and trying to use non-opiate oral analgesics, preventing nausea and vomiting, stimulating gut motility, removing the catheters as early as possible, and perioperative, and lastly the audit of compliance. This has been started all over the world, and one of the pioneering sections or divisions is actually the division of colon and rectal surgery in the Department of Surgery. That is the division where Dion and I belong to. These are pictures of the initial ERAS multidisciplinary workshops we had. You even see a picture of the former Dean, Alberto Rojas, who is also a colorectal surgeon as well. And we work together with anesthesiologists, even psychiatrists, physical therapists, rehab medicine, and the anesthesiologists, so many other people, nurses. And we came up as a product of this particular workshop. These are our outputs: the colon cancer protocol, the rectal cancer protocol, and anesthetic considerations and recommendations as well. Okay? So it's important to show everybody this multidisciplinary nature that this new paradigm shift has to have. Okay? And most of the models and successes really have involved colon patients who undergo elective colon and rectal procedures. And how are we cascading the ERAS nationally? Let me just mention and focus on not on all of those issues, but on the more common ones. So just to articulate the audience. Many of our practices today really have no basis in that. Things like, do we really need our bowels to be prepped before we have undergo colon surgery or rectal surgery? Do we really have to keep our patients on nothing by mouth or NPO 6 hours? These are things even in one of the hospitals I still practice in, is even 8 hours. NPO is 8 hours. IV fluid management, we routinely give D5 containing or normal saline, and standard practice among many surgeons is to use at least 3 liters of fluid per day to maintain urine output. And our patient will not be cleared for surgery unless we reach a hemoglobin of 10, or else they will need to have transfusion initially cleared. And the practice of resuming feeding only once the patient has passed flashes or has passed gas. Let us examine these common practices one by one. Mechanical bowel preparation. How many of you have had this? Na-bowel prep kayo prior to a colonoscopy, kahit colonoscopy man lang. Sino? Sinong aamin? Studies have shown that hindi entirely harmless ang mechanical bowel prep. It has adverse physiological effects like producing dehydration as patients inevitably develop some kind of diarrhea during the procedure. It is distressing, right? Logic? He got distressed. He had to sit in his toilet soon after he took those agents. In fact, it is associated with prolonged post-operative periods, and as the stools become liquefied, there may be a tendency towards a higher incidence of spillage during the resection of the colon, which might increase the rate of post-operative complications. The Cochrane review, as early as 2011, which reviewed 18 randomized controlled trials involving nearly 6,000 patients, showed that there was no statistically significant difference between the patients who were subjected to a routine mechanical bowel prep, those without any bowel prep, and those in whom only an enema was used. There was no difference regarding the dreaded complications of anastomotic leaks, mortality, reoperation or having to go back to the operating room for another procedure, and even wound infection. Let's go to the next practice. This all started and was called the Mendelson Syndrome. Very few people probably remember or can recall who this guy was. But it was Mendelson who reported in 1946 that stomach contents aspirated to the lungs in the performance of obstetric anesthesia. It was this report by Mendelson which eventually led to the practice of routinely keeping patients on NPO. Marami ganyan eh. I remember when I was a first year resident or a second year rotator in urology, every time we did a partial nephrectomy, the patient was kept on complete bed rest without toilet privileges for about 1 whole week. The patient was just lying down, not moving, because they were afraid that the partial nephrectomy would reopen up and would cause hemorrhages. I tried to find out. There was no evidence at all such things that were really responsible for that moving a patient. And I found out what started the practice. Nagkaroon pala ng isang morbidity na pinagalaw yung pasyenteng na partial nephrectomy. Tapos, gumugo. Doon na nagsimula. Yung one anecdotal, sometimes an anecdotal experience, leads to dogma or doctrine. Ganon din ang nangyari dito sa NPO. Meron isang pasyenteng nag-aspirate then it was textbook truth from there on. But there is no true scientific backing. Experience has shown that there are really few aspirations in elective. I'm talking of elective surgery. I'm not talking of emergency operations. And that the risk of aspiration is associated not because of the operation, but because of the patient's concomitant or associated comorbidities. This is the truth about gastric emptying. The graph shows you that 50% of gastric contents are usually evacuated by the second hour, after 3 hours, ingested, and at the third hour, only 10% or less stay in the stomach. Gastric emptying is complete within 90 minutes for both carbohydrates and water, or a mixture of carbohydrates and water. So in 1.5 hours, tanggal na yun. So, again, in Cochrane meta-analysis on fasting from midnight does not reduce gastric content nor raise the pH. In fact, an intake of clear liquids less than 2 hours before surgery does not really increase complication rate. Even patients who are obese and have uncomplicated diabetes, hopefully hindi majority dito sa audience, have normal gastric emptying time. We should really just watch out for some specific conditions like diabetics with neuropathy, those who are pregnant, those who have bowel obstruction or have gastropathy. Clear liquids with a 12.5% complex carbohydrates composed of maltodextrins up to 2 hours before surgery, when given, have been found to be cause a metabolically fed state. So it is same as being continuing good nutrition. You're able to reduce preoperative thirst, hunger, and anxiety. I think most of your patients, those who undergo surgery, will always complain, "Dok, gutom na ako. Kailan mo ba? Problema ko, ginutom mo ako just before." It's one of the most unpleasant experiences that surgical patients will tell you. It also reduces the post-operative insulin resistance. There is less post-op nitrogen and protein loss. There is better maintenance of lean body mass and muscle strength. And it causes accelerated recovery. And these patients who were given clear liquids with 12.5% complex carbohydrates 2 hours were found to have a shorter hospital stay by at least 1 day. Sa atin, hindi masyadong problema yan. Dahil hindi masyadong mahal ang 1 extra day. But in the United States, where maybe 1 hospital day may cost you anywhere from $600 to $800 US, malaking budget. Safety data, again, a preoperative carbohydrate rich drink given about 2 hours pre-op has been administered to 5,000 patients in clinical studies, even in 150 patients before gastroscopy, and nearly 3 million in surgical practice with no adverse events before. So, the ERAS recommendation for fasting is to solid foods 6 hours, fasting only clear liquids 2 hours per day, and carbohydrate loading 2 hours with using clear liquids composed of a mixture of 400 ml, 12.5% rate of mainly maltodextrins. This is commercially available abroad. We're having a hard time procuring it. We're asking our dietary service to prepare a similar concoction so that we could try to duplicate what is being done ERAS among the Filipino patients we have in PH. Preoperatively, carbohydrate loading improves patient comfort, attenuates insulin resistance, minimizes protein losses, reduces complications with no effect on gastric emptying and reflux. And goal-directed fluid therapy is still an independent predictor for improved outcomes. Okay? I'm not going to any more detail on that. It's just that we are able to maintain fluid hemostasis when we give some amount of fluid just before the surgery. there used to be a paradigm which we used to restrict fluids. And then we went too far, we gave too much fluids. But right now we're trying to reach what we call optimal fluid volume for your patients as they undergo surgery. Kasi masama din naman ang liberal fluid protocols. Minsan madalas ganyan, di ba? Bago operahan, insert ng IV, o baka ma-dehydrate, low natin. But that can lead to increased risk of fluid overload, peripheral edema, hypertension, even ARDS. The third common issue is with regards to blood transfusion. The tradition has been that we should never operate electively on a patient whose hemoglobin is less than 10. But less than 10, usually hindi i-clear hanggat hindi mo natin transfusan enough to raise the hemoglobin. But as early as the year 2000, that is 15 years ago, we published in the Philippine Journal of Surgical Specialties this evidence-based clinical practice guidelines, co-authored by Dr. Laudico, Dr. Ramiro, and I think I was one of the co-authors here. The traditional 10-30 rule, or hemoglobin of 10 or minimal hematocrit of 30, as a transfusion trigger, should no longer be utilized. So as early as 15 years ago, there was already evidence. Level 1, category A. Pero many of our colleagues have not, hindi siya pinansin. Hindi pinansin. In fact, in many hospitals, hindi ka talaga makakapag-opera kung hindi minimally 10. And then we also made the conclusion that normobulimic patients with acute anemia of cardiac disease or cardiac disease may benefit from RBC transfusion using a trigger of 7. In fact, the risk of, we have found that preoperative transfusion, RBC, within 72 hours prior to surgery start time really increases the post-operative complication rate, nearly threefold. So it's blood transfusion increases, in fact, the risk for hospital-acquired infections. There are worse short-term operative outcomes for transfusions given to cancer patients in terms of 30-day mortality, complications, length of stay, and associated patients who were transfused during their elective surgery have been found to be associated with poorer long-term survival in mammoth colorectal cancer. Okay? So, in fact, there was a study in the New England Journal of Medicine quite recently. The lower versus the higher hemoglobin threshold for transfusion in patients with septic shock. There was no statistical difference in mortality if you use 9 or 7 as your trigger for transfusion. It was 45% when you use 9, 43% when you use 7. There was no difference also in the rates of ischemic events, severe adverse reactions, and the requirement for life support. And look at, in terms of you are a hospital administrator, the statistically significant difference in the packed RBC that you need to use. If you use 9 as your trigger, they ended up utilizing 3,088 units. If you use 1,000, if you use 7 as your trigger, you use only less blood. And we know how difficult it is for hospitals still, kahit 21st century na tayo, hindi pa rin natin makumbinsi yung mga kababayan natin na mag-donate regularly ng dugo, right? Ang hirap-hirap pa rin. We always have to resort to this blood donation drive, operation blood brother, But we just have to use evidence and common sense. We can reduce unnecessary blood transfusion. Just pareho lang po ang outcome, whether we use the 10 or 9 or the 7 as our trigger. Okay? So, those are just some of the common practices that we are trying to change with ERAS, Enhanced Recovery After Surgery. And what are the preliminary lessons that we have learned? Mahirap pa rin mag-institute ng change. It's very difficult. But by using a multidisciplinary approach, involving our partners in the care of our surgical patients, using teamwork, communication towards establishing a multidisciplinary program, attention to detail, and refinement. We're finding out that, minsan hindi natin talaga pwedeng gamitin yung ERAS for the more complicated colorectal surgical patients. It's better to be utilized in the garden variety, relatively complication-free procedures. And the need for us to always review and audit our results every so often. And then giving feedback to all the participants. And then still introducing changes in the protocol as necessary. Okay? Compliance with the ERAS protocols have shown that with increased compliance, the length of stay is dramatically reduced and the readmission rate is also reduced. The more components of the ERAS that you comply with, and also complication rate in patients who undergo colorectal. In fact, in this coming May, there will be an international ERAS convention in Washington, D.C. And hopefully, this can be rolled out, involve other surgical patients as well, or to undergo elective surgical procedures in other parts of the anatomy. Okay? Let me end this by once again inviting you to the first ASEAN Patient Safety Congress, which our alma mater, the UP College of Medicine, will be hosting together with the College of Nursing and the College of Pharmacy. This is a regional event. This takes the place of the Grand Scientific Symposium that the college hosts every year. This is the first time that the Grand Scientific Symposium will take on a regional or international flavor. We have about 10 confirmed international speakers already, 3 from Singapore, 2 from Japan, and 5 from the United States. In fact, the foremost authority on the development of teamwork skills in developing multidisciplinary teams in taking care of patients and producing safer and better patient outcomes is coming over from the Department of Defense of the United States. This is the model of teamwork which they are using to train hospital teams all over and accredit hospitals all over the world. So you're all invited. We have actually a booth downstairs near the registration area. For those of you from the provincial areas, you may want to register or be early registrant because the registration rates are much cheaper than the on-site registration. Okay? So we hope to see you there because really we all want to produce better quality care. We all want to produce safer care for our patients. Maraming salamat.